and I hope I'm audible. We are still very few, just 30 people. So in this week we want to have I should call them a series of lectures. And we shall be covering the pelvis. Today we shall mainly cover bonny pelvis. And if time allows, we also cover the pelvic wall in general. In another lecture, we shall concentrate on appreciating the perineum. We shall be covering the perineum. We shall look at the urogenital and the anal triangles, but that is a very good thing. I think we shall combine it as well with the pelvic viscera. So I want us to cover the pelvic viscera at once. I think it's better to cover it that way. We appreciate it better when we cover it as using regional anatomy. So we shall look at the pelvic viscera once, and then we look at the pelvic vessels. So as we're looking at the pelvic vessels, it will lead us into the pelvic vessels, where we shall see the supply of each of the viscera. But majorly we are talking about the rectum, the vagina and the uterus, and then anteriorly the urinary bladder, and of course a small component of the urethra. And after that, we shall also look at now the nerves of the pelvic cavity or pelvic innervation in general. And then we shall look at the individual contribution to each of these viscera. And I think this will also lead us to covering the lumbosacral plexus. And I think with that, we shall be done with the pelvis. So last time we were supposed to continue with the urinary bladder and the urethra. I feel that it's better to first cover the pelvis. We see where the urinary bladder fits, and later on when we are covering the pelvic viscera, we shall start with urinary bladder, and we will look at its growth and histology as well. So in today's lecture, we want to describe the bonny pelvis and pelvic wall, that is the ligaments and the muscles that attach on the bonny pelvis. We shall differentiate between the two subdivisions of the pelvis, the true pelvis and the false pelvis. And then we shall try to look at the characteristics of a female pelvis, comparing them to the male pelvis, and how it's advantageous in the female. We shall describe the pelvic. Generally, we shall describe all the walls of the pelvic cavity, including the pelvic floor, what we normally refer to as the pelvic diaphragm. And we shall describe the muscles that form this diaphragm. I think we shall solve this, the arterial and nerve supply. We shall set to the next lecture when we are covering the pelvic arteries and vessels and then the pelvic nerves. So we shall start with the bonny pelvis, and we should appreciate the difference when someone is talking about bonny pelvis, the pelvis, and pelvic cavity. So when you are talking about the bonny pelvis, we are talking about the bones that form the pelvic cavity, specifically the bones without adding any other component. So bonny pelvis is a bowl-shaped or basin-shaped ring of bones, and it generally connects the vertebral column to the lower limb, specifically to the femur. And this connection is very important because the pelvic cavity forms part of trunk. And so if the weight is coming, all the weight that is carried by the body right from the head continues to be to the bones within the vertebral column. And that's why the vertebral column on its own has to be strong and in doing it intercalated with vertebral discs because of carrying that whole weight of the body. So the moment the weight reaches the lumbosacral region, but the lumbosacral joint, it is passed on to the bonny pelvis. So the bonny pelvis has to be strong enough to hold onto that weight that it's being passed on. Any weakness in that was fractures, and particularly the fractures of the lumbosacral joint are very, very common because it's at that point that the weight is being passed on onto the pelvic cavity. So the bonny pelvis is composed of those four bones, the paired hip bones or the innominate bones that generally form the anterolateral walls, and then the sacrum, which is fused bones, and of course the coccyx. Sometimes some books attempt not to include the coccyx, but surely it is part of these bones, because we shall see that it forms a very important attachment of the pelvic diaphragm. So these bones are connected by four important joints, and we shall see that it's also lined by muscles, generally four muscles. Let me make a reminder that I'm looking at the bonny pelvis in general. But I expect you, please take this very importantly. When you're doing your personal reading, don't just end reading about the ilium, the ischium, pubis. I expect you to read about these video bones. When it comes to the ilium, read about its surfaces. Read about spines, the anterior spines and the posterior spines, the superior anterior spines, the inferior anterior spines. And the moment you do this, you are going to appreciate it's from the notches, greater sciatic notch and the lesser sciatic notch, because eventually these notches form foramina with the attachment of the subspinal and the tuberal ligaments from the sacrum to the ischial bone, they cease to form to be notches. They now form foramina, the greater foramina and the lesser foramina. But for you to appreciate this, you need to read about these bones individually. Still, when it comes to the pubis, for example, you would appreciate when you do the reading that the pubis is going to form what we refer to as the body of the pubis, and then this is connected by two arms, the rami. So we shall have a superior pubic ramus and then an inferior pubic ramus. Understanding the individual parts of these bones is very important, like we shall see in the coming slides. And also, of course, in your clinic, once you're performing the procedures in clinical pelvimetry, you will need to appreciate what the superior surface of the pubis is, what the pubic symphysis is, and what the superior surface is, what the posterior body and the anterior body are. So without reading about the individual parts of this, you will not be able to appreciate such aspects. The hip bone, the innominate bone, is generally made of 3 bones, and at birth, these bones have not yet fused. They are instead united by a point here, something that we are seeing here, what we refer to as a triradiate cartilage. Of course, as someone advances in age, the cartilage, or this joint rather, keeps on narrowing and the bones eventually fuse. So at around 16 or 18 years, the hip bone has fully formed, meaning that it has fully fused. So you can see how important it is when it comes to the teenagers, that because this bone has not fused, but also that because the pelvic cavity as a whole has not fully developed, it is really a risk for a girl to become pregnant, because there are higher chances that, because this has not fully formed, is going to rupture and cause fractures of these bones. Okay, I think, okay, we can see the triradiate cartilage here, forming a joint between the ilium, the pubis, and then the ischium. And you can appreciate the body of the pubis here, and the two rami, or pubic rami, and then the body of the ischium and its rami, and then a very prominent alley or wing of the ilium, supported by its body. So we've been looking at the bony pelvis, but then we also use the term pelvis. So pelvis can be understood differently or can be defined differently. Generally, it's taken to be the region that is below the abdomen and actually continues with the abdomen, That is why sometimes we use the term abdominal pelvic cavity, because it's a continuation of the abdomen. Anatomically, we are going to refer to the pelvis as that region that is enclosed within the pelvic girdle, or that region that is enclosed within our bony pelvis. And we may ask ourselves right away, like I had noted in the last slide, the functions of the bony pelvis. And as we move along, we shall see various functions of the bony pelvis depending on structures of this pelvis. Generally, because it forms a cavity, we know that it houses and supports the pelvic viscera, the urinary bladder, and the rectum. And in the female, of course, there is the vagina and the uterus in between the urinary bladder and the rectum. And of course, on top of that, we shall see later on that it would also play a role in the functioning of some of these structures. For example, playing a very important role in fecal continence, that the structures within the pelvic cavity are going to play a very important role in defecation, playing a very important role in maintaining the urinary continence. In the female, we shall see that the pelvic diaphragm plays a very important role in keeping your vagina tight, because the muscles are forming a sling around it. And of course, very important to note that it's a very important aid for vaginal birth. Another interesting role we shall as well look at is trying to maintain the intra-pelvic pressure as a way of supporting activities that are going on within the abdomen and within the thorax. And we shall see, like in terms of calming, that it's going to facilitate such activities. So looking at the divisions of the bony, of the pelvis rather, we can divide the pelvis into two parts: the false pelvis, or what we call the greater pelvis, and greater pelvis because it's just above the lesser pelvis, which lesser pelvis is also referred to as the true pelvis. And what divides these two parts, the true and the false pelvis, is the pelvic brim. So if you were to look at this here, so I highlighted it in black as well. Maybe let me just, that pelvic brim is dividing our two, okay, yes, it's dividing our two pelvis. And if you are to look at false pelvis, the greater pelvis, it is that cavity that is enclosed within, right from the lumbar vertebrae posteriorly, come to the wings of the ilium with the associated muscles, the iliacus muscles laterally, and then anteriorly, of course, most of it is going to be covered by the abdominal wall, or the anterior abdominal wall. And then we come to the true pelvis. The true pelvis is starting from the pelvic brim downwards. So it will be that cavity enclosed between the pelvic brim, what we shall refer to as the pelvic inlet, and the pelvic outlet below here. So in other words, the true pelvis has a pelvic inlet, a pelvic outlet, and that is enclosed or forming the openings and the outings of the true pelvic cavity or the true pelvis. So from this, we can see in blue, we can see the true pelvis. And then a part of this still forming the pelvic cavity, but now this is the false pelvis, just that cavity within the wings of the ilium. Okay. So this is a larger version of this at least. So we can see the cavity starts from here. And you can see the wings of the ilium here. The muscles will come in, and then anteriorly you can see that it will generally be formed by the abdominal cavity. Up to this point, when we have the pelvic inlet. Very important here, the orientation of the pelvic inlet and the pelvic outlet. And this, of course, has a bearing on the orientation of our viscera, the pelvic viscera. So you can see the orientation of the pelvic inlet as compared to the outlet. If this is the inlet, so the outlet should come in this manner. They generally form an angle, but not at right angles to each other. And this is very important to note. And also physiologically during childbirth, this is also taken into consideration, that the moment the baby is moving from the abdominal cavity coming downwards, the baby is not going to move straight, but once he reaches our true pelvis, he has to make a turn, and at the end of it all, the movement is in a J form. It moves in this manner, and then once he reaches the outlet, he has to turn, and it kind of forms that kind of J-shaped movement. So I would really be interested in you telling me about what forms the boundaries of the pelvic inlet, and then what structures are forming those of the pelvic outlet, before we can look at the entire true pelvic cavity. So when you add the pelvic inlet, you can see posteriorly it is being formed by the sacropromontory. So these are parts that we have not gone through, but that I was telling you that you really have to go through them, because I will mention them, and you will only appreciate them if you read about the individual bones separately before you can incorporate them into the bony pelvis. So posteriorly being formed by the sacropromontory and the ali of the sacrum, or the wings of the sacrum, and these are the ali. Laterally, you can see it is being formed by the actuate line, the linea terminalis, That of course is going to be formed by majorly by the axial line, the pecten pubis and the pubic crest posteriorly, and then anteriorly, generally formed by the pubic symphysis and the superior surface of the pubis. When you come to the pelvic outlet, still you can talk about the anterior, posterior, and the lateral margins. Anteriorly, you can still see that it's generally formed by the pubic symphysis and small margins of the body of the pubis. Posteriorly rather, generally formed by coccyx. And then in this, because of its shape, sometimes we talk about the anterolateral and the posterolateral surfaces, margins rather. So the anterolateral margin being formed by the inferior margins of the ischiopubis ramus, and then the posterolateral surface being formed by the sacrotuberous ligaments from the sacrum, the istiotuberosity. Laterally, there are very important margins, the istiotuberosity, and this is a very important landmark as you're carrying out your procedures in pelvimetry, trying to assess the size, the fitness of the pelvic cavity for vaginal birth. One of the procedures you would carry out is trying to assess the distance between these tuberosities. So you would use your fisted hand, place it, push it against the vulva until when you get inside, and depending on whether this is wide enough or narrow, you will feel these tuberosities blocking your knuckles. So either outer knuckles will be blocked, and that would really indicate a much wider distance between the istiotuberosities, what we refer to as the bituberous diameter or the bituberous distance. But if it's narrow, you would realize that actually they are instead fitting within, in between your knuckles. So that would really show that it's a bit narrow, and it might cause difficult labor. Then, of course, the other very important landmarks to note as well is the pubic symphysis. This is also going to be very key when you're taking your diameters. Most importantly, when you're checking for the antero-posterior diameter, so from the anterior to the posterior diameter. But of course, still, when because you have to assess as well the pubic arch or the pubic angle, which is a subpubic angle. But on the posterior side as well, you are going to use your first two fingers to try and palpate the posterior margins of the pubic body. So you will also check for what we refer to as a retropubic angle, how wide it is it forming a very sharp angle, so undulated, is it widened, is it narrow? And then you are also going to use it for anteroposterior diameter. So as you're measuring the anteroposterior diameter, there is another landmark that is key that you use here, and what is on the superior aspect here, and that is the sacropromontory. So generally in the female, the sacropromontory should not be so prominent. Okay, let me use this. It shouldn't really be so prominent, because if it's prominent, meaning that if it is coming too much inside, it will be narrowing our inlet, that at the end of it we shall see an inlet which is this shape, kind of forming a heart shape because of narrowing. Yet generally in most of the female, a pelvic inlet should try to be in manner circular, such that even the cavity of its own generally tries to maintain that. And when you look at the pelvic inlet, outlet rather, it also roughly would take up that shape, that at the end of it all, you have a shape, a pelvis that is near cylindrical in shape. But if you have this kind of thing, you realize actually that the pelvic outlet also attempts to narrow much more, and it instead becomes a funnel shape. And you can see there is so much narrowing here, so much narrowing in the middle end. So there are high chances of difficulty in labor, because it compromises as well on the presentation. And at the end of it all, you're either getting occipital, posterior, which is not a problem, of course, still there will be, but then it may as well come with occiput transverse. So please take note of those landmarks. They are very important. Of course, sacrum and the part of the coccyx also is very important. You are going to palpate it, see how it forms. In women who shouldn't really find difficulty in vaginal birth, what I mean is that those with cavities that are sufficiently spacious, the sacral bones should have a much reasonable carving. So when you use your fingers after feeling the sacral promontory for you to be able to measure AP, you can now turn them on the opposite side to try and palpate, to feel the curve. Is it sufficient enough, or is it appearing in this manner? Because if it's appearing a bit straightened, still it will be narrow, the cavity. Okay, I think let's continue. So at the end of it all, remember what I told you, the orientation of the pelvic inlet as opposed to the pelvic outlet. And this is not going to enable the baby to come out straight, because the baby doesn't move in this manner. He has to maneuver and take up the corners of the pelvic cavity. So that's why it's very important for the baby to turn as he maneuvers through these inlet and outlet. And like I told you, moving in this manner and then trying to form another bend, a gesture movement. So let us look at some of the differences that we can see between male and female bony pelvis. Generally, the pelvis appears heavier and thicker. And all those landmarks we have been talking about are more prominent in males as compared to the female. On the other hand, the one of the female would appear much wider, though shallower but wider, to provide that sufficient space. And very, very important when it comes to the inlet and outlet, that they are larger. And like I said, for most of the females, it is near cylindrical. For a majority of the men, it should be more of, oh sorry, that's gone. It should be more of a funnel shaped. Oh, sorry. Okay, I refused. Funnel shaped structure. And what is making this near cylindrical shape in most of the females, the gynecoid pelvis, are these landmarks we are talking about. Whereas in the male, you are, let me use another illustration maybe. Okay. That whereas in the male, this sacropromontory is going to be more pronounced, so it is coming more inward. We have the istiospines. They are also more pronounced, sharper. And you can see the more they appear sharper, the more they are narrowing our cavity. And actually, these are the other landmarks that you will need to use when you are assessing for adequacy of cavity for vaginal birth, the istiospines, and they are also palpable. And then, of course, when you look at the wings, they will tend to be oriented outwards or bend outwards as compared to these ones that appear as if they are more bending inwards. This prominence of the sacropromontory at the end of it all will tend to form what most people would refer to as a heart-shaped pelvic inlet or triangular shaped pelvic inlet as compared to the circular pelvic inlet. And then when you look at the this joint here, the pubic symphysis, the subpubic angle or the pubic arch is much wider in the female as compared to the male. And as a matter of fact, when a female is pregnant and preparing for childbirth, the arch even widens, that it would go up to around 120 degrees. Oh, 112, about 110 to 120, and that is when it will be considered wide enough. But of course, it would still be good enough if it is not less than 90. That should be really the bare minimum. And why it widens it's because there is a change during pregnancy, which is hormonal influenced, that this plug here, this disc here between the pubic bones in a pregnant female, it would widen. It's already wide or larger in a female, but during pregnancy, it even widens further to allow more movement around this joint rather. And this movement is going to facilitate increased size, which is very important during vaginal birth. So in the pregnant women, it would even widen the more. So you compare that with the pubic angle in the male, which is much lower. So this is generally of much of what we've been talking about in the female. The thin and light as compared to the first pelvis, wide and shallow. And why is it wide and shallow? Because the wings of the ilium, the alley of the ilium, tend to rest outwardly as compared to these ones that tend to bend inward. The pelvic inlet generally circular as compared to the triangular shape, how shaped. Pelvic outlet still the same, roomy and round as compared to this one, which is narrow, and hence the funnel-shaped shape in android pelvis. Android more in the men as compared to the female. Ischial spines more prominent, so inverted as compared to the ones that are curving outward to maintain the roomy space within the cavity in the female. Then the sacrum short and flat as compared to the long narrow, and then still bulging inwardly to narrow the cavity, and then the subpubic angle much wider in the female as compared to the male. So at the end of it all, these pelvis in the female are generally classified or grouped into 4 different types. And this was done by one of the grandfathers of obsgyn. So we generally talk about these 4 variations: the gynecoid, android, the platyploid, and then the anthropoid. And this is whereas you would look at all the other components, landmarks, the space of the cavity itself, but generally they have an outstanding inlet that you can compare them basing on the inlet. But I'm not saying that is what they base on only to differentiate a gynecoid and android. They would base on the inlet, they would still base on the outlet, they would base on the landmarks we talked about, their prominences, how wide the first pelvis is, also. But we shall narrow ourselves to inlets. As you can see in this one, it's forming generally round as compared to what we have been looking at, the heart shape. heart-shaped inlet. So a majority of the women have this gynecoid pelvis, and it is what is normally referred to as the classic female pelvis. And it's estimated that 50% of all the women have a gynecoid pelvis with a round pelvic inlet, a roomy and generally round pelvic outlet, leading to a near cylindrical pelvic cavity. The android, a very small percentage of the women have this android. It is actually generally taken to be a male pelvis. That doesn't mean that there are no females that have android. It may present some challenges in childbirth because, like we have been discussing, that at the end of it all, it tends to form a near funnel-shaped appearance of the cavity. So narrowing that cavity, you can see the prominence of the sacropromontory and the sacrum or the sacral bones generally are going to narrow this cavity. Your spines come in more pronounced in the cavity. So not only the pelvic outlet will be compromised, but the middle lane also in between the cavity here, it's also going to be narrowed. And yet for a gynecoid, you would realize that if you're measuring these diameters, they are almost generally, they would almost generally have the same diameters. If I take an example, if this is maybe 13 or 12, you'd realize that roughly this would end up at 12 and then at 12. Generally, the pelvic cavity diameter in between here is the same diameter as oblique diameter. And then the anteroposterior diameter is normally the opposite of this diameter here. So anteroposterior diameter of the pelvic inlet is the same as the transverse diameter of the pelvic outlet. And similarly, the anteroposterior diameter of the pelvic outlet is the same as or equal to the transverse diameter of the pelvic inlet. The platyploid, a very small percentage of the men would have a platyploid type of pelvis. And then the anthropoid still a small percentage. These are associated with commonly associated with bridge presentations. We had talked about the occiput or posterior presentation of the head of the baby. That the posterior aspect of the head would present, and that is what would could be to maneuver. And yes, in this you can see that it is oval transversally, and the anthropoid is actually oval vertically, or what they are calling the oval long. So this would, could also present with not really an oxport. This one actually it would even be dangerous, like oxytransverse, that the baby tries to maneuver with this presentation. But generally, when you look at this, it is normally an anterior presentation, oxport anterior presentation. So if this is the head of the baby, wow, I don't think I can draw it. The baby is fairly extending the head. Let me use the arrow. Trying to extend the head fairly backwards. When it comes to the oxport, instead the baby tends to bend the head onto the chest. So in this way, you instead see this part presenting first. That's why we talk about occiput posterior. Okay, this is just a summary that A and E are most commonly in males, and we are talking about the what we were referring to as the classical male pelvis, the android, and then the anthropoid. B and A, the classical female pelvis, very common in the whites, and A as well, and then B and C in black. So the glenoid and then the anthropoid are common in the black. Platyploid generally uncommon. So even as we look at so much of that, we should appreciate that knowledge of these diameters, knowledge of the shapes of these pelvis is very important in obstetrics, and we've already talked about how important they are during childbirth. But also knowledge of that actually is used, is taken advantage of in forensic science, that you can use the thickness, the size of the hairs of the bony pelvis to differentiate whether it is male or female, on top of the other landmarks that present. Orientation of the pelvic cavity in an anatomic position, we see that the axis and the symphysis pubis lie in the same vertical plane. So this would make sacrum appear spirally, and the pubis and the symphysis appearing anteriorly and inferiorly, antero-inferiorly. So if the coccyx is spirally, then the sacrum, then the coccyx would appear more posterior. And we shall see when we are looking at the joints that the ligaments play a very important role. Otherwise, our sacrum and coccyx would keep on moving up and down, but they are fixed in position by the ligaments. So in this, we still have ourselves of because of that orientation, that pelvic inlet is not really in the same plane as the pelvic outlet. So, pelvimetry. We're just going to briefly look at some of the key diameters that could be regarded very important in pelvimetry. And like I said, pelvimetry is going to help us assess the fitness of the bony pelvis, female bony pelvis, to sufficiently carry out a vaginal birth. But as you're doing these measurements, they might be useless if you again don't compare that with the measurements of fetal head. So you would normally as well talk about cephalopelvimetry. And in that cephalopelvimetry, you are actually trying to compare the fetal head size or diameters, and you will compare them with the pelvic diameters. And so, like I had noted before, that generally, when you look at the three diameters, the antero-posterior, so antero, and then the posterior here, because this is the coccyx. Roughly about 11 centimeters, it would be equal to the transverse diameter of the pelvic outlet. So you can see roughly 11. And then the oblique diameter generally remains the same. You can see here it's for the outlet. And the diameter of the pelvic inlet would equate to the anteroposterior diameter of the pelvic outlet, roughly about 13 centimeters. So there are so many diameters that can be measured. We already talked about the bituberous distances, by spinous distances, to assess how wide the spinous processes are, or how wide the ischiotherostes are. We shall talk about three very important pelvic diameters here. And that doesn't mean that you measure these diameters and that is all. As a matter of fact, these are not even measurable. The only measurable diameter would be the diagonal diameter conjugate. Otherwise, you cannot measure the anatomical conjugate. And similarly, it would be difficult for you to really measure the obstetric conjugate, but it can be assessed using the procedure that we talked about much earlier. And that is the tuberous distance. If you remember, we talked about the tuberous distance. Using your fisted hand, you're going to use the help of your knuckles to assess if you are touching, the knuckles are touching outwardly the ischiotubers, or instead if they are fitting just in between the knuckles. So that is going to assess how wide or how narrow. And in that way, you are saying the width, your conclusion will be about width. Is it narrow? Is it normal? Or is it Yes, wide, normal or narrow. Then the bispinous, the ischiospines. We talked about trying to palpate the sacropromontory, trying to see how prominent is it. And of course, the sacral vertebrae themselves, or the arch, trying to pass your fingers along the sacrum, or the sacrum. See how curved is it? Is it straight? Is it? Come to the retropubic angle, and I want you to be careful. Don't confuse the retropubic angle and the pubic arch or the subpubic angle. These are different angles, and actually you would assess differently. And we already said that the subpubic arch should really be generally U-shaped, but it even widens in pregnancy. Yet we want for the male will be V-shaped. So you're going to assess this as well, about how wide is it or narrow. And the same will go to the retropubic angle on the posterior margins of the body of the pubis, and of course the symphysis itself. So that's why you're going to do the palpation. It's unfortunate, I was forgetting that the video is not on, so I was illustrating the hands. Then we shall now talk about our three conjugate diameters. The anatomical conjugate. And the anatomical conjugate is going to be that distance between the superior margins of the sacropromontory and superior of the posterior surface of the symphysis. So that is the anatomical conjugate. But I want you to appreciate that this cannot be measured. We have another one. From the margins of the sacropromontory to the inferior margins of the posterior surface of the pubic symphysis. So this is what can be measured. I don't know if someone can appreciate the reason as to why this can't be measured practically. Can someone try to tell us why it is difficult to measure this practically, the anatomical conjugate?
Yes, excuse me.
Yes, please.
It's just a try.
Yes.
Yeah, I'm looking at this this picture down on the
Yes.
lower right.
Mm.
When you insert the finger, meaning that the inferior border of the symphysis pubis is what you are touching with your finger actually.
Yes.
On the upper part of your fingers. So that's how it becomes practical to measure this one. Whereas the superior margin of the symphysis pubis will not be hard for you. It will not be easy for you to touch it because of the muscles.
Yes, because it is really out of reach. And then the obstetric diameter, or the obstetric conjugate. That is generally this distance we are seeing from the promontory to the posterior margins of the symphysis. And that is very, very important, that it is actually the practical distance we are interested in from the sacropromontory to the closest point you are going to that you'd be able to let me say touch. Though we are getting this from the diagonal conjugate, that the diagonal conjugate should be 1.5 to 2 centimeters more than the obstetric. But the obstetric is the most important. And why it is most important, if you look at our pubic symphysis, it is really going to appear flattened. That is why the distance taken from here and from here would have been the same as the one taken from here, but because it would appear that way, it would instead appear in this form. So depending on the extent of the curving here, this would impact on our obstetric conjugate. And this obstetric conjugate is actually the narrowest. And I want you to mark this. It's the narrowest fixed sound, fixed distance or diameter through which a baby should pass during the vaginal birth or vaginal delivery. It is the narrowest because you look at this, if you measure it from here, it would still be a bit wide. Come here, it will be a bit wide. When you come here, you can see already compromised. That's why we are talking of 1.2, 1.5 to 2 centimeters less than the diagonal conjugate. And if we are to recall the anatomical nomenclature, I hope you recall it. What is this presentation called? Anatomical presentation. This is a female. And this is the vulval region. This is a thigh, and another thigh has been cut. So this is the region of the perineum. What view or what presentation is this anatomical presentation? I've made it even better. Patricia. Patricia never attends lectures. She logs on and runs away. Ezerith, can you remind us of this? We normally talk of several positions, the anatomical position. So which one would this be? Because you're going to use it so much in your examination.
It is dorsal position.
It is?
Dorsal position.
Dorsal position.
Either dorsal or lithotomy position.
It is?
I think it is lithotomy position.
Yes, yeah. Now you are being more anatomical. And I would expect Ezerith, Patricia, Kataike to be even more conversant with this. One of the reasons is because they are female.
Yes, I'm around.
You are around. Who is that? Patricia? Who is it?
Yeah, it's Patricia.
Okay. This is freezing. Okay. So we shall not so much on this, but what I was trying to say is that it may be a bit meaningless for you to concentrate much on the pelvic diameter as we are putting into consideration the standing of the fetal size. But I don't want you so much to get through this because these are topics on their own when you reach your clinical years. So briefly, we want the pelvic joint, and the idea four joints. Sometimes we add the lumbosacral joint because of its importance, but it's really not a part of these four joints. It is somewhat outside. So our two joints are the sacroiliac joint, the iliac joints, the symphysis pubis, and then the sacrococcygeus. We shall go through this a bit fast. The sacroiliac joint, a very important synovial joint, because it's eventually through this that the weight is going to be transferred before it can come to the lower limb. So it is a strong joint, and with irregular contours. When you look at the center of the alley of the ilium, that's articulating with the sacral wings. They are not really smooth, but they tend to form rugged surfaces, and this forms a somewhat interlocking mechanism of this joint to further strengthen it, and that makes it the movement very, very minimal. But interestingly, is that actually during childbirth, all this is influenced, and the movement here appears to slightly increase as so widening and the increase in movement here. The important it transmits the body weight the lower limb, and it is stabilized by directly it is stabilized by three joints: the anterior sacroiliac, what we are seeing here, then on the opposite side posteriorly we see the posterior sacroiliac, and then the interosseous sacroiliac joints, ligaments rather. Indirectly, it still gets support from two important ligaments, and that is the sacrotuberous. We already talked about this, and then the sacrospinous, which we can see in another illustration. And these are somewhat fan-shaped or triangular-shaped ligaments. And in addition, you can see that these are the ligaments that we looked at that were giving us posterolateral margins of our outlet, particularly the sacrotuberous. But also, in addition to these margins and support to the joints, the sacroiliac joints, they also help us to form the lesser and the greater sciatic foramen that is derived from the two notches, the lesser notch and the greater sciatic notch. When we are looking at the pelvic diaphragm, I think we can see better structures of the foramina. In this orientation, we cannot see it well. Then the other key, well, before I go there, I think you can see now from this view, a fan-shaped kind of ligament from the attaching from the ischiospines and the medial and lateral margins of the coccygeus, the sacrospinous, the sacrotuberous. Still, you can see it is fan-shaped, narrow downwards, but on its superior attachments, it widens because it has a long stretch of attachment along the vertebral bones. So this also plays a very important role in stabilizing our cavity during transmission of this of the loads of the weight. So you can imagine the entire weight of the body transmitted through the column, and once it reaches the lumbosacral joint, ideally, if you look at the curvature of the human body, if this weight hits, there will be a movement at the lumbosacral joint that this behind part here, but the sacrum would be forced to move upwards. And that would mean actually the coccyx is also moving. On the other hand, the weight of the body tends to hit here at the lumbosacral joint, and then it's going to force the sacrum to tend and rotate in this manner, and then the coccyx will tend to rotate in the opposite sense or opposite manner. So to prevent this, you can see that there is a very strong attachment of these ligaments, the sacrotuberous and the sacrospinous ligaments. So stabilizing our pelvic or the pelvis, formation of the greater and sciatic foramina from the notches. So with that attachment, you can see that these were notches, the greater notch and the lesser sciatic notch, but these two ligaments complete the enclosure here to form the greater sciatic foramen and the lesser sciatic foramen. The same illustration showing us sacrotuberous, sacrospinous with our foramina. The other foramina we shall find would be a very small foramina here. Most of these being covered by the obturator membrane. Still trying to show the same. And now these are the foramina we're talking about, and we talk about structures that pass through these foramina. as we continue with our discussion, we shall see some of them. We shall see, for example, the piriformis. Remember during your dissection that you were using the piriformis as a landmark. This is the piriformis as a landmark to look for the sciatic nerve, but also the superior gluteal nerve and the associated vessels, because the superior gluteal nerve and the associated vessels were the ones that are moving or exiting superior to the piriformis, and then inferior to the piriformis are also other structures. The majority of the rest of the other structures were passing inferior or below the piriformis, and then the superior gluteal nerve was passing superior. I hope you remember that. So the pubic symphysis, fibrocartilaginous joint, and we said this is wider in the female, but also very importantly during this plug widens to facilitate for more space. Like I said, the rhombosacral joint really is not really a part of these joints, but we normally talk about it because of its importance. Actually, as a matter of fact, many pathologies of the back are going to occur around this region, the lumbar region, and very many are going to affect the sacral joint, because it's a point of transition from the vertebral column to the pelvic cavity, to the weight being transferred there. But we shall not, time is running, so much look at it, but you can do reading on it. Okay, about the enlargement and then relaxation of the pelvic cavity as a whole. We've already looked at many of these. Then the pelvic walls. Generally talk about four pelvic walls: an anterior wall, a posterior wall, and then lateral wall. Sometimes there is a preference of referring to it as posterolateral, because there is no clear-cut boundaries. And then, very importantly, the pelvic floor. And this pelvic floor is what we normally try to spend much time on, because this is what we refer to as the pelvic diaphragm. So these pelvic walls are a contribution of the bonny pelvis, the associated ligaments. You can see there are already ligaments running here, and then from here downwards we saw those two, sacroiliac and sacrospinous, and then of course now the muscles, the pelvic wall muscles, of course with the associated fascia. We shall see the inferior fascia, superior fascia covering the pelvic diaphragm. And this fascia is normally continuous with fascia of the abdominal wall. So in case of any pathologies, they can be transported upwards because it's a continuation. So starting with the anterior pelvic wall, we can see that it is generally formed by the posterior margins of the pelvis, the rami, and then the symphysis itself. And this anterior pelvic wall is directly related to the urinary bladder, because the urinary bladder will be dwelling here, only separated by a potential space, which we shall look at, the retropubic space, very important space as well. The retropubic space. I think you should relate it to the retropubic angle, and that is the space between the posterior margins of the pubic symphysis and the urinary bladder. A very important space still, because it is continuous with the space within the anterior abdominal wall, particularly when we talk about the fascia. And still, either bleeding, if bleeding occurs, or abscesses, they can move along this stretch, the retropubic space, but generally filled with a retropubic arch. Posteriorly, the posterior wall generally formed by the coccyx and but additionally, there is a contribution that you saw here. Remember, there was an interruption here to form a notch, and within this notch, there is a major muscle that runs within it to attach outside forwardly on the femur, and that is the piriformis. So you can as well add the piriformis as the other component of the posterior wall, the piriformis muscle. Let's look at an illustration of this piriformis. So this is the piriformis running from the middle three sacrovertebrae, exits the pelvis to attach at the trochanter of the femur, and together the piriformis is going to play a very important role in lateral rotation of the femur. So in this we can see the attachment of the piriformis muscle after it exits the pelvis. The lateral wall generally formed by the obturator internus and maybe the associated membranes, obturator fascia. A small contribution by the sacrotuberous and sacroiliac ligaments, and maybe a part of the hip bone. So in this we can see laterally, this is a posterior. In laterally we see a small contribution of the hip bone, but the majority of this formed by the obturator internus, and this obturator internus is normally covered by a membrane. There is fascia here, obturator fascia, and it obliterates the diaphragmina save for a small space that is left. And this will also run away from the pelvis to attach onto greater trochanter of the femur. Okay, I think lastly we'll look at the flow, and that flow is what we refer to as the pelvic diaphragm. A funnel-shaped flow, as you can see. From the funnel shape, And very important that it separates the cavity above, which is the true pelvis, from a very important region below it, the perineum. And because of its funnel shape, if you can see, so these forms a part of the lateral wall of the cavity. You can see the obturator membrane, and of course part of the bone. Then the wall comes in this manner. That's why we call it being funnel shaped. It kind of forms a V shape. And because of this V shape also, it creates, separates the cavity and creates two spaces here that we shall later look at, or the foci, ischioano, ischiorectal foci, which can also be of key clinical significance. We shall look at this when eventually we are looking at the perineum. So the floor of the pelvic cavity is formed by these two muscles, the levator ani muscles and the coccygeus. So let us look at these muscles. The pelvic diaphragm. Forms the closing of the pelvic outlet, except in the midline where it leaves a space. And this is created by the levator ani muscles that don't form in the midline. And this very important hiatus for the passage of the urethra in the male, and the urethra, the vagina in the female. But of course, below it, it will be covered by another membrane. And we shall look at this membrane later on, the urogenital membrane. Sorry, the urogenital membrane. So just below the pelvic diaphragm, there are spaces underneath these bones, and even on this opposite side, and those are what we are calling the ischioano, ischiorectal foci. It can be clear in here. So there is this space here that is created, and you can see this is the floor. This can be a part of the viscera going through, maybe the urethra, maybe the rectum. And then this is the lateral wall formed by the obturator internus with the associated coverings, fascia. And this pelvic diaphragm plays a very important role in the stability of the structures that pass through or that exit the pelvic cavity. Importantly, they play a very important role in the stability of the urethra in both the male and the female, the vagina, and the anorectal junction, or stability of the rectum. And because of this, we shall hear muscles like the pubo-vaginalis, pubo-urethralis, because they tend to form a syringe, or they tend to form kind of a thread around these structures. So we shall start with the levator ani. Though, of course, the functions of these muscles, the levator ani and the coccygeus, is generally the same. The coccygeus doesn't play a very important role per se, it acts as if it's a support to complement the functions of the levator ani. So the levator ani muscles, it forms a thin show of muscles, thin but wide, broad rather, running all the way from the pubis to the coccyx and from the lateral margins or the lateral pelvic wall to come and unite with their fellow in the middle. So it will run from these sides and generally moving medially, posteromedially. It's important to note that their thickness might vary depending on the positions, but also depending on their points of attachment and also the structures they surround. They can be classified as puborectalis, pubococcygous, or iliococcygous. I think the names can even give you a clue. Puborectalis, the coccygous, pubis to the coccygeal ligament, bone from the walls of the alley to the coccygeal ligament, particularly from the pubis to the coccyx, and then laterally from the obturator fascia medially or posteromedially. The same thing they are trying to show us here. A very important point here, and then the iliococcygous, the puborectalis, and I wish I could widen this here. Pubococcygous rather, and then you can see the puborectalis, and the puborectalis from the pubis, and once it reaches the region of the rectum, it forms fibers around it. And this is from the opposite side. This is from one side, and then the ones also from this side would also come and do the same on this. The same flow they are showing us with these three muscles. You can see that coccygous completes the flow of the cavity, or completes the pelvic diaphragm. And then we move laterally to the piriformis, rather posterior to the piriformis and laterally to the internus fascia, hiding the obturator internus. So in other words, it's kind of basin like a bucket. This manner. Laterally there will be, but then the flow. So this would form the entire flow from here to here, from a bucket, because you already saw that it tends to form a V shape. In this illustration, we can see some of the aspects we shall be covering later on. So, the pelvic flow. The pelvic flow is this one. But remember, we also talked about a region below the pelvic floor, and that was the perineum. So this entire region here is the region of the perineum, and they are trying to show us some of the structures of the perineum. But this is will be another lecture, our next lecture. So we shall study the puborectalis from the pubis body or body of the pubis, and it runs posteromedially to connect with its feather on the opposite side. and at the end of it, it's going to form a syringe around the anorectal junction. You can see this syringe. And this plays a very important role in fecal continence, that its contraction and relaxation allows the anorectal junction to either open up for defecation or it keeps it in check. So in other words, it plays a very important role in controlling movement of substances along this junction, and that's why we talk about it being playing a very important role in fecal continence. It also gives off some fibers that may surround the vagina, the urethra, and so we talk about the pubovaginalis and then the urethral vaginas, because of the small fibers that are given off. I don't have good illustrations, I think, I don't know. I don't have a good illustration of the coccygis, but it's actually the main part, the widest part of the three fibers. But it will still run from the pubis posterior medially to meet its fella, and it will eventually attach at the anococcygeal ligament and the coccyx, then the perineal body. Somewhat a similar point of attachment to the iliococcygeus. So still as it moves, it's going to encircle the urethra. So as you read, you may come across a muscle. They're talking about a pubourethral muscle. It is generally a levator, and the fibers that go to encircle this. In the male, similar fibers that go to the vagina would go to the prostate gland, and you talk about a puboprostaticus muscle. Then finally, muscles are going to feed into the perineal body, and that is the puboperinealis component. So that is how the different components of this muscle are being named. And because of the way it gets into around the vagina, the urethra, still plays a very important role in supporting the prostate and then the vagina. So there is a constriction of the vagina and then stabilizing of the perineal body. And because of this kind of support, you realize that if this is our prostate gland, later on we shall see that there is something that passes through it, and it is the prostatic urethra, or the prostatic part of the urethra. And then this muscle is forming around here. Either side, of course. So it's going to play a very important role in the opening of our muscle here. Let me think of, well, I cannot, I think I've put it a little bit up. Let me put it here. So, sorry, it's so much up in the prostate, but here, and then it will play a very important role in opening of our urethra at this region. So in that way, you realize that it also plays an important role in urinary continence. Coccygis, like I said, same as the pubococcygis, but only that it will run so much from the tendinous arch of the obturator fascia of the ischial-spine, but most posteromedially still to attach onto the anococcygeal ligament and the coccyx, and generally the perineal body. In our last slide, we just want to look at some of the actions of the levator ani, and these are going to be derived from the attachment we're looking at. So we already looked at it from a sling around the pelvic viscera, and one, it will support it, keep these in position. We talked about the maintaining of the intrapelvic pressure. So it will resist the rise in intrapelvic pressure during certain activities that is a result of or requires training and impulsive efforts of the abdominal muscles. Otherwise, if the pelvic diaphragm would play that role, then we would really see pressure here instead diverted into the pelvis, that we see an increased pressure here, and that would have an impact on this force instead moving upwards to eject or to cause a coughing or whatever, if you have done some kind of aspiration in the lungs, to cause that to eject whatever is in there outside. We talked about fecal continence as a result of the puborealis, mainly around the rectum or the anorectal junction. We talked about tightening of the vagina, constriction of the vagina. I think some people also attempt to do some good money out of this, because I don't know if Ezerith is there. She may be well conversant with this. I think women of around that age of Ezerith, sometimes they attempt to, Ezerith, what do you call it? Is it vaginal tightening? Ezerith has already run away. Hey, so when did you last attempt this tightening? Ezerith has run away. Okay, let's leave Ezerith's vagina alone. So apart from serving as a vaginal sphincter, because it also has an effect, it is quite the space between the vaginal opening and the urethral opening in the female is very minimal. There are two different aspects, but very, very minimal. That whatever tends to circle this, somehow by default, it also goes upwards to encircle this. So if it is a pubovaginalis, you realize that there are also some fibers getting off to encircle the urethra, and it would still play an important role in urinary continence. The last muscle, of course, is the coccygeus, the ischial coccygeus, and generally plays a supportive role to the levator and muscles. Tomorrow, we are going to look at, is it tomorrow? Tomorrow we are going to look at the perineum. And I think it's a bit short. It can lead us into pelvic viscera, where we shall now continue with the urinary bladder. We shall just have a brief mention on the rectal junction, because I think it is something you covered in the gut. It is very important to appreciate those fingers and then appreciate, because the blood supply is somewhat associated. And also in the anorectal blood supply is very important, because anastomosis that comes in, there is an anastomosis within the blood vessels of the rectum. And because of that, sometimes it causes a very common condition. I think we shall, but I think you've looked at that. As a result of a consequence of portocaval anastomosis, you remember the conditions that may arise. Did you cover that? People are quiet. Marvin? Okay, have a good day. We meet tomorrow. I hope tomorrow there is a lecture.